Greetings everyone. My name is Kimberly Julian and my roll number is BP1650106. I am a student of 4th Prof Morning and my group number is 17. Today we are going to discuss a case study based on pulmonary embolism as assigned to me by Ma'am Shahana. So let's dive in. So before we get into the details of the disease, the pulmonary embolism and its case study, we basically need to know where the disease arises from, how it is diagnosed, and what other treatment options available. So, in order to see that, let's begin. Basically, pulmonary embolism does not occur directly. It is something that progresses from a disease known as deep vein thrombosis. So, what exactly is a thrombosis? A thrombosis is an unwanted clot that is present within a blood vessel. When this clot detaches itself and starts circulating in the blood, it is termed as an embolus. So, basically, both thrombus and emboli are dangerous as they can obstruct the deep veins and cause them to be deprived of oxygen and nutrients and other things. So you might have already concluded what pulmonary embolism is. As we already know, the term pulmonary is for lungs, and like I have already described embolism, in conclusion, we can see that pulmonary embolism is basically a blood clot that is occurring inside the lungs. And like I have said, it is a progression of deep vein thrombosis, meaning the emboli can basically detach itself from the deep veins and obstruct the lining of the lungs. Basically, what it does is cause damage to the parts of the lungs that it's obstructing, and it can cause restricted blood flow, decrease in oxygen levels, and it can affect other organs as well, as lungs are supplying blood to various parts of the body. As you can see in this diagram, the thrombus here is detaching itself from the femoral vein and it is circulating in the blood, and finally it goes on to attach into the lining of the lungs. And here we can see that the emboli is embedded in the veins of the lungs. So this is how pulmonary embolism progresses. Now, what are the signs and symptoms of this disease? Like, how can we tell that a person is suffering from pulmonary embolism? The person might have irregular heartbeat and loud heart sounds. Since the heartbeat is irregular and erratic, there must be breathing issues, restlessness, shortness of breath, tachycardia. Anxiety might arise, and the pulse might be weak. It might also manifest itself as symptoms on the skin, like bluish skin, etc. Now, what can we basically we can't really tell if a person is suffering from pulmonary embolism or deep vein thrombosis as they are internal issues. So, what exactly can we do that can tell us that that our patient is suffering from such disease? Basically, perform diagnostic tests. In diagnostic tests, we have very kinds of tests, like some tests use radioactivity, some tests use x-rays, and so on. So the basic tests that are associated with today's case study are x-rays, venograms, ct scans, and electrocardiograms. X-rays and venograms are basically non-invasive procedures that use x-rays to determine the internal lining and internal imagery of our body to tell us where the problem lies. CT scan is also a non-invasive procedure, and in this particular case study we are going to use a VQ scan. as we all already might know that ECG, which stands for electrocardiogram, measures the heart's electrical activity. So, what are SOAP notes? So, in order to do a case study, we need to know what exactly is a SOAP note. A SOAP note is basically a method of documentation that we use as a pharmacist to make our study of the patient's condition easier. So, basically, we divide our study and our treatment plan into four components. That is the subjective part, the objective part, the assessment, and the plan. In subjective part, we note what is the patient's complaint, and in objective part we analyze what are the primary signs and symptoms the patient is suffering. After analyzing the subjective and objective status of the patient, we basically assess and diagnose what exactly might be wrong with our patient. And foreseeing the assessment, we plan what the therapy might be given, we plan what pharmacological help the patient might need, and then we document the whole criteria. So now moving on to a case study, and then we will prepare S.O.A.P notes of the case study. So, what exactly is a case study? We have a patient named DJ, and he is 38-year-old, 90-kilogram man who has developed a swollen left calf, and he complains that it is painful and warm. Slowly, the swelling has increased in his calf, which led him to ask for medical help. He has also started having right sided pleuritic chest pain and does not have shortness of breath. His medical history suggests that he was an ulcer patient, but it has been successfully treated, and the time that has passed now since his treatment is 4 years. Physical examination tells us that he is already an obese man, but due to the swelling, he has an abnormally enlarged leg, and there is tenderness in this. We further have other laboratory and clinical data that is written here along with our tests that we are performing, that is the ECG, the venogram, and the VQ CT scan. We also have performed coagulation tests, and all the data are recorded in this case study that you see on your computer screen. So now, breaking it down as a SOAP study, we will conclude what this patient what might be wrong with this patient. So for the subjective part, we note down the chief complaint of our patient, and that is his swollen leg and the pain he is complaining of. We have recorded his history, as he has stated that he started having this pain several days ago, and it radiates in his entire chest and as well as his leg due to the swelling. There is mild to moderate tenderness in his leg, and he has chest pain and does not suffer from shortness of breath. We have already discussed his medical history, so I'm not going to repeat it here again. But now we will move on to the objective symptoms. So basically, his vital signs include a 90-kilogram weight, and his blood pressure is higher than usual. We already know that normal blood pressure range is 120 by 80. Here it is high, but his heartbeat is normal. His respiratory rate is also high. According to these clinical findings, we can't really prove that it is pulmonary embolism right now, as a lot of other diseases share the same common symptoms. So what we will do is we will proceed to our laboratory data. In it, we see that the hematocrit is very low, but the serum creatinine level is normal. The arterial gases, oxygen and carbon dioxide are slightly lower than normal. However, his blood pH is in the normal range. Other laboratory data suggests that his prothrombin time or PT is normal, his INR is also normal, and his plate count also lies within the normal given range. But now we can confirm that he is suffering from pulmonary embolism because of our radiographs. Chest radiography and VQ lung scan suggest that he has pulmonary embolism, whereas ECG shows signs of sinus tachycardia, which are a prominent symptom of pulmonary embolism. Furthermore, we can confirm that the venogram is positive for the defect in the iliofemoral vein. Like we discussed before, pulmonary embolism is basically where the embolus is detaching itself from a previous deep vein. So here we confirm that the iliofemoral vein is the one that has a thrombi in it, and the thrombi has detached itself and is now circulated and present within the lungs. So now we will assess his condition. So now we are using the symptoms and all our radiograph findings to conclude what exactly he has. So the symptoms that included the pleuritic pain and the swelling of the leg. There is also a loud heart sound, and there is decrease in arterial gases. These all are signs of pulmonary embolism, which are further verified by our radiograph findings and venogram findings. Weight is also increased in the patient, which and he is obese, as already mentioned in the case study. So we know that obesity and genetic factors contribute to coronary heart diseases and deep vein thrombosis, which might be the case here. As patient is obese, it might have culminated to occurring of a DVT, and now the patient is also suffering from pulmonary embolism. All other clinical findings are normal, hence we conclude that the patient it has pulmonary embolism and deep vein thrombosis. However, we are not discussing how to treat deep vein thrombosis here, so we will just discuss the medical treatment for pulmonary embolism. So, moving on to our plan, the non-pharmacological management is to reduce stress, do light exercises, use compression stockings. Basically, compression stockings are a type of socks that prevent the swelling of the legs and the feet. And since we know that our patient is suffering from a similar condition, we might advise use of compression stockings. Reduction in weight and overcoming obesity is an important factor in the non pharmacological management, and it's the pharmacist's job to counsel the patient to have to do the exercises and to have a good diet that will help him overcome his obese condition so that the disease does not progress further. Moving on to our pharmacological treatment options, we have anticoagulants and we have thrombolytic agents. In anticoagulants, we have heparin and low molecular weight heparins as well as fondaparinux, and we have warfarin. Heparin is injectable and it is a rapidly acting coagulant, whereas fondaparinux is also an injectable pentasaccharide anticoagulant, but it is more predictive in pharmacokinetic profile. So it needs less monitoring than heparin. We can give heparin and we can also give fondaparinux dependent upon the patient condition, and we will analyze the patient condition and then we will decide what kind of drug we need to administer. In case of warfarin, warfarin is an oral anticoagulant and it is used for the prevention and management of both deep vein thrombosis and pulmonary embolism. However, it is only used when the international normalized ratio is between uh, 2 to 3 range. Thrombolytics are also used, however, it is not recommended in this condition as the patient condition here is not that much worse. In patients where there are acute massive embolisms which are seriously interfering with the quality of life, then we give the thrombolytics. Drugs that are included in this class are urokinase and streptokinase. So the pharmacological management for pulmonary embolism can be IV unfractioned heparin, or it can be low molecular weight heparin or fondaparinux, both administered by subcutaneous injection. The reason we are using subcutaneous injection is because fondaparinux is well absorbed from the skin and it has good bioavailability there. Unfractioned apparent therapy can be started with a loading dose of 7,200 units according to the body weight, or it can be followed by continuous infusion of 1,600 units per hour. The alternative to this therapy, if we do not want to give this therapy due to certain reasons, we can start with subcutaneous low molecular weight apparents, or we can use subcutaneous fondaparinux, and he can receive the fixed dose of enoxaparin 90 mg subcutaneous Q12 hourly according to his body weight. This therapy should be continued for at least 5 days, and then we will substitute to the warfarin therapy. The reason we need to substitute or move to the warfarin therapy is because we cannot keep giving the IV therapy or subcutaneous therapy. This is basic knowledge for us pharmacists that we only go towards the IV or subcutaneous route when there is no other option. Depending on the condition here, since we need to stop the progression of our pulmonary embolism, we will start with the IV therapy. However, we will not continue it for further on because it can end in lipodystrophy and other issues. So we will change the warfarin therapy when patient becomes stable, and then warfarin therapy will be continued for 3 or 6 months. If the patient shows good progression, then the duration of this therapy can be lower, but usually therapy lasts from 3 to 6 months. It is basically dependent upon the recurrence of venous thromboembolic events or the risk of bleeding. And the thrombolytic therapy, like I said, should be reserved for patients who have massive embolisms and who are not hemodynamically stable. So, what will we monitor when we start both these therapies? The major risks associated with anticoagulant use is hemorrhage. Whenever there is risk of bleeding or the patient starts bleeding, we need to stop therapy and analyze our assessment and plan all over again. However, if the patient is not prone to bleeding, we will not stop therapy and continue with it. Usually, patients that are not in such a worse condition do not bleed easily, so the therapy is successful. However, we also need to monitor for other adverse effects such as skin necrosis and purple toe syndrome. Skin necrosis is also associated with warfarin use alongside hemorrhage and purple toe syndrome. In purple toe syndrome, basically, it occurs from 3 to 8 weeks after the initiation of warfarin therapy. And what occurs in this case is that with effect of pressure, the coloration of the skin becomes normal. However, when the pressure is not applied, the skin turns to a purple color and there is pain associated with the syndrome. So in all of these conditions, we need to stop the warfarin therapy and continue with other anticoagulants. However, if such adverse effects are not occurring, then we will continue with this therapy. So So I hope all of what I explained has is clear, and this these therapy and these pharmacological managements are common in the case of pulmonary embolism. However, in other cases, there are other anticoagulants and thrombolytics that can be suggested and vary accordingly to the disease. Thank you.